Hello everyone, I'm Dr. Anthony Mazzella. Welcome to our continuing education seminar series on understanding and treating the challenging, personality disordered patient. Throughout this comprehensive program, we will delve deep into the various facets of personality disorders with a particular focus on narcissism, examining each facet from different psychodynamic perspectives. In each one-credit seminar, we will explore a particular challenging or narcissistic trait, think about its origins, and finally, through case examples, how to treat the specific narcissistic trait under discussion. This comprehensive approach will lead to more effective treatment outcomes and healthier interactions. In this seminar, I aim to review a selection of theoretical literature on depression. I will attempt to integrate various theoretical frameworks illustrating through clinical examples how theory can be effectively applied to facilitate change while maintaining a deep understanding of the patient's subjective experience. Let's look at the literature now. The literature suggests that there's overlap between depression and narcissistic personality disorder. Research indicates that major depressive disorder is the most common comorbid condition among individuals with narcissistic traits, or NPD. These individuals often grapple with a chronic need for self-enhancement and a deep sense of inferiority, making them particularly vulnerable to depression. Factors such as self-esteem dysregulation, life events, and interpersonal struggles contribute to this vulnerability. It's crucial to recognize that focusing solely on depressive symptoms can overlook the complexity of the narcissistically disturbed personality, including the painful experiences of what I would call the big three. 1, self-esteem fluctuations. 2, emotional dysregulation, and 3, self-criticism. In other words, all three of these play a major role in adolescent depression. In particular, the problem of self-esteem fluctuations and emotional dysregulation in individuals with narcissistic traits is well illustrated by a quote from an adolescent patient of mine. This quote, which I believe accurately captures the essence of the depressed teenage experience, reflects the intense inner turmoil that can lead to or exacerbate depression. And I quote, "Certain that others are observing and thinking about them, teenagers develop an inflated opinion of their own importance, a feeling that they are special and unique. Many adolescents view themselves as reaching great heights of omnipotence and also sinking to unusual depths of despair." End of quote. This statement highlights how the adolescent mind, with its heightened sense of critical self-awareness and emotional extremes, can become particularly susceptible to the onset of depression. In terms of number 3, right, the third sort of the big three, self-criticism, depression has also been defined in terms of superego development, the complex phenomena of guilt and self-directed aggression. An individual who is sad or is mourning, which is a healthy process, by the way, may feel diminished, but he does not feel, and I quote, "I am bad," or does not feel that they deserve punishment. That's the guilty part. That's the critical part of the superego development that I'm alluding to. It is also thought that there are 2 types of depression in adolescence. The first type is based on a symbiotic tie with the omnipotent, need-satisfying other and involves feelings of shame, humiliation, inferiority, inadequacy, and dependency. And by the way, I'm going to illustrate this with the case of Mary in just a moment. In the second type of depression, there's a great deal of guilt, self-reproach, and a punitive superego. And I will illustrate this too in a moment in the case of Mary, because both of these coexist. It's not one or the other. It's just a question of which one predominates. To return briefly to the quote I just mentioned and look at it from a different theoretical perspective, when we say that teenagers develop an inflated opinion of their own importance, a feeling that they're special and unique, and that they may view themselves as reaching great heights of omnipotence, it becomes evident that these behaviors and perceptions align closely with what psychoanalytic theory refers to as, and I quote again, manic defenses. So I'm saying, yes, that I'm suggesting that this feeling of omnipotence is in part a manic defense. These defenses serve to alleviate, or at least I should say deny or disavow, the profound sense of loss and insecurity that adolescents experience during this developmental stage. Factors such as separation from parents, social isolation, the challenges of forming peer groups, and the fluidity of self-esteem all contribute to this tumultuous period. It's very important to note that these defenses of narcissistic omnipotence do not alleviate the pain associated with loss. That is why you often see these depressed teens, and this is back to the quote, also sinking to the unusual depths of despair. I hope I'm beginning to demonstrate that depression is a complex phenomena, and it seems to me that effective treatment must take into consideration all of these dynamics, along with the nature of the primitive defenses and one's self and other representations. All of these factors coexist, contributing to the intricate landscape of depression. Recognizing the coexistence of these factors, plus some other factors that I'll mention momentarily, is crucial as it underscores the importance of employing multiple conceptual frameworks to better understand and specific intervention techniques to better treat and address this complex mental health issue. Thinking now about therapeutic approaches, let's shift our focus to a practical case, allowing us to delve into the lived experience of an adolescent struggling with depression. A quick disclaimer alert. When presenting clinical material, in order to protect the anonymity of my practice and patients, I weave together a composite case, an amalgamation of diverse cases. However, this narrative represents authentic stories along with my actual interventions. This is the case of Mary, a young woman who began a 2-time per week treatment with me while she was in high school. She came to me after what one might call a severe depressive episode, which interfered with her day-to-day life, like studying, sleeping, and eating. She lost all interest in school and was barely functioning. From what I witnessed in the early days of treatment, there were intense feelings of worthlessness, guilt over not performing in school, loss of concentration, and quasi-suicidal thoughts like, I would never kill myself, but I don't really see the purpose of living. According to all reports, at one point Mary was a diligent student. She devoted herself to her studies, had a few close friends, and refrained from drinking or substance abuse. At first glance, there were no apparent triggers for her depression. We gradually uncovered that preceding her descent into depressive episodes often lay a rupture of some kind. While these depressive episodes appear to arise spontaneously, seemingly without cause, from her perspective, Over time, we identified a pattern linked to loss. The insights I'm about to share stem from her initial year of college. Like many adolescents, Mary was navigating the complexities of social life and identity. Her journey into the world of sororities unravels as a powerful illustration encapsulating the whirlwind of emotions ranging from initial euphoria and eager anticipation to a profound abyss of devastation plunging her. When I say plunging, I mean into the depths of crippling self-doubt and depression when she was confronted with something that she did not expect. When she was rushing the sorority, she did not get an invitation, that's a bid, to her sororities of choice. What I'm about to describe is the lead up to her discovery of this heartbreaking and devastating realization of profound rejection. Rejection often precipitates depression. That's what I had mentioned a moment ago. She reports that she was getting ready, texting her parents. She was so excited, so sure. She said, I was going to get invited to pledge the sorority that I wanted. This is amazing. I feel great. I have on my high heels, my skin-tight jeans. This is great. Then she opened the bid card only to find herself overlooked by both of her two top choice sororities. This is stressful. This is the next 4 years of my life. This is my social life. It sucks. It hurts. My other friends are getting in. I knew my life was over. She was crying. My friends didn't know what to say to me to make me feel better. I don't know what to do. I have to transfer to another school. This is the end of me ever having friends. This is the end of my social life. I have nothing. I don't want new friends. I think you're getting a sense of where she was emotionally at this moment. She spirals deeper and begins her self-reproach. Something is wrong with me. I'm not good enough, pretty enough. I'm weird. Do I not know how to hold a conversation? I feel horrible. She's crying. She can't talk. I tried to help her move from what we call in my field a dysregulated to a more regulated state. And she begins to express that the other sororities are so cool and I'm such a loser. I'm so embarrassed. I am thinking about my friends. They'll all go to the coolest parties. I felt so shitty about myself. And people asking, why wasn't I in, X sorority? They must be saying, what's wrong with you? I will be excluded from the pre-game sorority parties, and even if I go, I would be an outcast there. Let's breathe for a moment and think about all of what's happening here, because under the weight of mounting depression and anxiety, what Mary began to tell me was that she confided in her mother, like she turned to her mother with this, and in response, she said her mother urged her to focus on the positive, emphasizing that she was accepted to a sorority. Her mother questioned why she always seemed to dwell on the negative. Reassuringly, Mary reported, she was told by her mother that everything would be all right. Let's think about this. Let's try to conceptualize what's happening with Mary. While there's a wealth of insights to extract from this brief vignette, my focus will be on what I deem central to understanding depression. The narrative underscores the depth of her emotional response, marked by tears and a struggle to articulate her feelings. The inability of her friends to provide her with solace hints at a profound sense of isolation and emotional anguish that eludes verbal expression. Now, you may be saying to yourself, but Mary was able to acknowledge and verbalize feelings of what? Humiliation. So how is that eluding verbal expression? I can respond to that. What I would say is, Mary is unable to employ these words in a manner that grants her a sense of detachment from her emotional experience. In other words, these expressions are lacking the transformative power that the symbolic function of thinking often carries. In other words, words are not being used symbolically at this moment. They're being used more like a weapon, if that makes sense. I'll delve a little deeper into this aspect shortly, but for now, it's crucial to recognize that Mary, initially at least, lacks the capacity to symbolically represent her inner emotional state. Like I said, she's using these words as a weapon against herself, not to really understand something new or discover something new about herself. In psychoanalytic terms, one way to view her heightened anticipation and excitement may represent what I mentioned when I said in the literature. Remember, I said there are two types of depression. I mentioned that earlier. The first type is based on a symbiotic tie with the omnipotent, need-satisfying other, and involves feelings of shame, humiliation, inferiority, inadequacy, and dependency. Remember, I said this earlier. In other words, there is a narcissistic merger fantasy of the grandiose self with the ideal other. In this case with Mary, what's the ideal other? That's the sorority. However, the heightened anticipation and excitement about bid day and joining the ideal other can also be described as a manifestation of what I call defenses. Remember, I also mentioned defenses earlier. This could be the primitive defense known as splitting. What is splitting? Let me just illustrate it. The initial anticipation and positive emotions are evident as Mary prepares for sorority bid day. She expresses overconfidence, overexcitement about the prospect of joining the sorority she desires. Her looks, tight jeans, and optimistic outlook. Everything is what? Do you remember? Great, ideal, perfect. These are her words. As can be anticipated, this quickly changes to what? Do you remember? Devastation, deflation, and then depression. Mary becomes completely overwhelmed by the emotional impact of not receiving the invitation. For those of you who may like an alternative conceptualization, here's another one. We can also say there is an intense, affective arousal. So there's affective arousal. Mary is very excited. Then a lack of emotional attunement. This is just another theoretical way to conceptualize the response that Mary has. So in other words, and I quote, a mismatch. There's a mismatch, like a no smiling other, no smiling, supportive, affirming caregiver. And what's that followed by? An extreme narcissistic injury, as defined as, again, what we call in my field, the field of psychoanalysis, and I quote, a shame state. So this is a shame state because of this emotional lack of attunement. There's this mismatch. Okay, let's go back to splitting and how everything quickly turned to all bad. The realization that she has been overlooked by her sororities of choice left her feeling rejected and bad. This transitions to another noteworthy element in the conceptualization of depression, self-reproach and the emergence of a negative self-representation. Mary begins to engage in self-reproach, questioning her worth and attractiveness. She wonders and quickly concludes that she's not good enough, pretty enough, or capable of holding a conversation. This negative self-perception contributes to her emotional distress. In the theory of melancholia, that's what it was called back in the days. Freud wrote a paper on this called Mourning and Melancholia. In this paper, he spoke about the superego and it is portrayed as a powerful force that can turn against the ego with violence. This is akin to Mary's experience where she engages in self-reproach. That's like the punitive superego that I mentioned earlier. She begins judging her worth and attractiveness. That's the way it turns against the ego. That's what Freud said. She attacks herself. The punitive aspect of the superego, evident in the theory, aligns with Mary's negative self-perception, contributing significantly to her emotional distress. For instance, Mary spoke about not being invited to her sorority of choice, which means people must be saying, and remember I'm quoting, "What is wrong with you?" unquote. In her mind, you see, they are judging her. But that's the superego. This echoes Mary's struggle as she not only attacks her worth, but anticipates being judged by others. And then you could question as well, is this not, and I'm sure you heard of this word projection, is this not a projection of her own judging and critical superego? In other words, she gives it to everybody around her. So other people are judging her without really recognizing that this is emanating from within. The fear of judgment becomes a source of shame. Now we're back to shame, and intensifies her depression. But why, you may ask, does she judge herself in such a harsh way? This is a complicated question, but in part, if the external environment has failed her, in this case, the bid from the popular idealized sororities, this unconsciously triggers prior and much earlier failures. In healthy development, and I quote, "The child can accept the reality of exclusion if they already establish firmly the good internal objects." Unquote. What does that mean? What are good internal objects and how do they get established? In other words, if there has been more love, support, and understanding, more than there has been of what? Anger, neglect, judgment, or hate. Or we could say this in another way. If there has been, I'm borrowing a concept from Winnicott, good enough mothering, he calls it good enough, right? The mother, the parent does not have to be perfect. They have to be good enough. If there's enough of that, what we see then is the establishment of what? The good internal object. This gets internalized. We see here that Mary cannot tolerate being excluded. It's almost as if she did not have something good to fall back on. We can then speculate that Mary's catastrophic breakdown over loss, separation, and exclusion harks back to the earliest period when such a condition is not simply uncomfortable, but threatens life in itself. That's when one is very young. They don't have the capacity to tolerate separation and loss. In other words, there's a good possibility that there is some unsettled trauma dating back to Mary's childhood. I also mention trauma because we could see in Mary's reaction to not getting a bid to her sororities of choice that she enters into a fight or flight mode. This is like a traumatic reaction. This response is a classic manifestation of trauma, where the body instinctually reacts to perceived threats, highlighting the deep connection between trauma and emotional dysregulation. How, you may now be asking, do I effectively treat someone in this state of emotional dysregulation? Let's pivot here and focus now on therapeutic interventions. Mary found herself overwhelmed with emotions. She was flooded. When confronted with such heightened states, my initial priority is to guide individuals from a dysregulated condition to a regulated one. In Mary's case, my approach involved deliberately slowing down the pace. Now, some may find this repetitive. My intention was to foster a space for a questioning conversation. This method aligns with the influence of prominent psychoanalysts such as Bion and my late supervisor and good friend Richie Lasky, emphasizing the importance of an inquiring presence over definitive interpretations. The essence is to encourage individuals like Mary to participate in a thoughtful dialogue. My technical approach is an emphasis on, and I'm quoting, verbal thinking. I want to make clear that Mary, amid her tumultuous emotions, is engaging in thoughts. It's crucial to understand that she's in a state of hyper-arousal. Remember before I called it a shame state? And at the moment, her ego is flooded and needs some assistance. Perhaps one could call this an ego-supportive approach. To facilitate this exploration, the focus is on helping Mary activate her reflective capacities so she can think about the unfolding events. And I'm emphasizing this, she, because this is what we want to do in a good therapy or a valuable therapy, is to help the patient begin to develop the capacity to think, to reflect and think. And I'm pointing out that she had thoughts. Mary had many thoughts, but thoughts tend to be persecutory in nature. As you could tell, she was spiraling. She felt very persecuted. So we want to slow her down and help her develop a capacity to think. Initially, the interventions are designed to accept the legitimacy of her disappointment, inquire about her sense of specialness, attractiveness, and popularity, and what it feels like to be at the center and what she imagines herself to be when she, in her mind, is in the most popular sorority or at the best parties. In other words, we're getting closer to what she imagines. This is her fantasy. And this is part of psychodynamic psychotherapies. We want to get closer to the patient's subjective experience. So I may ask questions like, what do you imagine? Who will see that? In other words, when she's center stage and in the popular sorority, who will see that? How will they respond? How will you feel? These are all acts of, and I quote, containment. And again, you've heard me say this if you heard any of the other seminars, appreciating her subjective experience, because all of this is what's going on actively in her mind. What's the goal? Why am I doing this? The goal is to transform what Bion termed, and I quote, undigested facts, unquote. In other words, Mary's raw emotional experiences, we want to transform them into cohesive verbal thoughts, thinking. Unraveling, this is the goal, is to unravel the intricate layers of her internal world. A quick reminder, Mary reported that under the weight of mounting depression, that she confided in her mother. Remember that? In response, do you remember what her mother did? Her mother urged her to focus on the positive, questioning why she always seemed to dwell on the negative. Reassuringly, she was told that everything would be all right. When I explored her feelings about this conversation with her mother, she slowly began to talk about feeling, and I quote, invalidated. And do you see that, by the way? Can you see how the mother's response was invalidating? The mother was attempting to be there for Mary. I get that. But in her response, by telling her just to do the opposite, was invalidating. The mother's response not only suggests a lack of empathic understanding, but also sends an implicit message. What is that message? That we don't talk about, that we don't deal with negative emotions. In my perspective, this represents a pivotal focal point. Mary and I gradually began discussing her expectations of finding emotional understanding from her mother only to encounter an abrupt deflation, akin to, again, in psychoanalytic terms, a shock-induced deflation. That's like a narcissistic deflation. Interestingly, you may have noticed this already, this closely resembles her reaction when she opened her bid card and discovered a rejection. In moments of vulnerability and distress, she did not get a bid to her sororities of choice. Her experience is one of a mother. I know she's not actively thinking about that, but I'm asking you to imagine that this re-evokes an experience with her mother who responds in her own dismissive and invalidating way. So all of this comes back alive. Thinking about invalidating responses, I want to briefly digress to share an example from my podcast, The Narcissism Decoder. In a recent episode, I interviewed a father who was struggling in his relationship with his teenage daughter. This conversation underscores that which I am trying to present right here, but I want to emphasize it because I want to demonstrate that this is not just theoretical, but a real and pervasive issue in many families. So here's this little clip from the podcast.
Talking to you or emailing you rather and listening to your podcast, it has opened me up to pause and say, well, wait, let me rephrase that. How is she going to take that? But there's another part of me that struggles with, me telling my daughter, hey, you're not 12 years old. Get out of bed. You got responsibilities. You're 16. You got to go to school. Let's go. It's not really shaming her, but it could come across as I'm shaming her because I told her she's a 12-year-old. So I struggle with
what you're implying. Yes, that's right. It implies that you're acting like a baby.
But I also think there's got to be a little bit of tough love. Like, I don't want to be like a wet washcloth her whole life because she didn't have any kind of structure. So it's a fine line to me that I don't know how to teeter on.
Let's think about it just for a moment, because you could think back maybe to this example of the way that you were trying to help her, to motivate her to get out of bed. The question becomes, is it effective? And when I say effective, I don't even just mean in the moment, but does it further the cause? Does she feel better overall? Does she have less trouble getting out of bed day to day? Or do you feel she pushes back on you when you say something like that, or has a reaction, or maybe there's a boomerang effect and the next day she doesn't get out of bed, or she doesn't get out of bed for a week?
No, what happens in my case, I stopped doing that because I learned that from listening from your podcast, like how to approach and how to talk. And I'll reference something in the White Depression also, but she felt attacked. She felt hurt. I'm going to hurt you now, Dad. Even it was her subconscious. And she didn't go to school that day. So her reaction was, you hurt me, I'll hurt you.
That's what I meant by the boomerang effect. That's exactly right.
But
and it may not be so conscious, but they have to figure out a way to say, I am not a baby, and you are not going to talk or treat me in this way, and let me show you. You think you're going to control me? I'm the one who's really in control here. I will stay in bed all day. In fact, maybe I'll stay in bed all week now.
Exactly what happened.
In healthy development, one can feel frustrated and angry, but they can process, they can verbalize, they can accept, and they learn to express, in other words, with language. They express these feelings if given the correct support. We can see in this little clip that I just played that this daughter was not given the opportunity to express her feelings about what? Why she was not motivated to get out of bed and go to school. Instead, she was shamed. So the goal is to give somebody, if you have a patient like this, a depressed patient, is to give them the space by expressing this curiosity about what's going on. Why is she interested only in staying in bed? And all of this is in the service of doing what? Helping one begin to put an inner experience into words using language. And that's the symbolization. Remember I said before, that Mary lacked the symbolic capacity, that she used the humiliation as a tool against herself. So what I'm suggesting now is when you can use the words and you have the acquisition of language and you could describe an inner feeling, now you're expressing your feelings symbolically. I hope that part makes a little bit of sense. Initially, the work with Mary around her depressive episode revealed an image of a dependent child and an emotionally unresponsive, rejecting parent, that she was always trying to please and get attention from. And just to make this part very clear, we can see the reenactment of this image. She was all dressed up, trying to please the sorority mother, that is. Remember I said symbolically the sorority represented the mother, not consciously. So she's dressed up, excited to finally please the mother, have that magical merged relationship that I mentioned earlier, and she was left feeling rejected when there was again yet another misattunement, triggering a rapid onset of negative affective shame, distress, which is very common in depression and narcissism, propelling the previously hyper-aroused, remember she was very excited, like a manic defense, hyper-aroused self into an unmanageable, depressed shame state. There's that quote that I mentioned at the very beginning of the seminar, right? Remember I said the adolescent sent me this quote. That captures it nicely, and that's exactly what Mary is experiencing. So in terms of technique, from my perspective, the goal at this moment, again, through the active act of containment, I use the word containment again, and getting closer to her subjective experience, as I mentioned earlier, is to help her metabolize. That just basically means to put this into words, to digest the humiliation. But now it's both past and present. See, it's no longer just about the sorority and not getting a bid, but now it's also about this much more complicated and meaningful interaction. Well, the history of many interactions like this, I would imagine, with her mother. But what about her aggression and her punitive superego, you may now be asking? How do we work with the aggression? Yes, we have to keep in mind that the shifts in self-esteem, the misattunements, shame, and humiliation may also be an indicator of a superego dominated by a highly aggressive inner critical voice. This is like the second part of the aggression. The depression, right? There was two types of depression, and this is the more punitive piece here. So let's look at this. The rage that arose from frustration and humiliation when her desire for love went unfulfilled was not immediately evident. Remember, she came in crying and anxious and feeling ashamed. There was nothing there about aggression. This could have been due to repression or the possibility, like we mentioned earlier when I was talking about theoretical perspectives and what's in the literature, we have to keep in mind the possibility that the anger was transformed into depression. But let me put that differently. The anger might have been redirected inward. So it gets redirected, and it's what? It's directed at herself in the form of attacking herself for being a failure. Over time, we were able to explore a much more conflicted side of Mary, that of an angry child self and a neglectful, abandoning, or invalidating other, which could be her parent, right? So the goal in the treatment shifts a little bit. So as new material emerges, the goal changes, and the goal at this point was to do what? To permit and facilitate freer expression and recognition of these unknown feelings around her angry self. And this comes later in the treatment. I just want to make a note of that. And again, if you had listened to any of my other seminars, I tend to save this stuff till later because anger is a little bit harder for most depressed, narcissistically disturbed patients to deal with. The initial presentation and what needs to be cleared away or looked at first is the shame and humiliation. But make no mistake, the anger is there as well. It's not like it's not there, but like I mentioned earlier, it just doesn't predominate. But it's there, and you have to flush that out too. Let's pull all this together, reflect on where we are, and begin to wrap up things. In trying to understand Mary's depression, we've identified several contributing factors. First, we discussed the lack of symbolic thinking, and I demonstrated how to move her into a more regulated state where she could begin to think. Remember, instead of having the persecutory thoughts, which lead to further depression, further shame, we want to help our patients begin to think, which is that reflective capacity that I demonstrated earlier. Second, we spoke about splitting, the desire and expectation for a perfect, omnipotent self, right? Like the way she was dressed for midnight, to merge with an idealized, perfect sorority. See, that's really important to get at as well, because these unrealistic expectations, so there's typically a mismatch, and then incredible disappointment, frustration, deflation, narcissistic injuries. There's a lot of different words or concepts we could use to describe this, but that's why it's so important to get at the splitting. Third, we talked about the shame state. When there's intense affective arousal followed by a lack of emotional attunement, so here it is, leading to the mismatch. Yes, this is what I just mentioned. An absence of a smiling caregiver. Remember that internal representation of the good enough. Remember I said that before, from when I borrowed from Winnicott, culminating in extreme narcissistic injury, a drop in self-esteem, and humiliation, which rendered Mary more vulnerable to depression. So there is the link between this mismatch, the feeling of shame, right? There's no internalized good smiling other, and then there's the injury. Narcissistic deflation. Actually, if I could digress just for one moment, I did a whole podcast episode on something that was entitled something like, is it depression or narcissistic deflation? And oftentimes, patients may come to you after having been in treatment for many years, treatment for depression, but you have to always keep in mind, unless someone is specifically trained to deal with issues around personality disorders, such as narcissism, the personality disordered part of the patient may go unnoticed. It may go undetected and therefore untreated. So therefore, you want to always be aware that it may not be just a mood disorder, but the two of these sort of commingle with one another in the way that I'm describing here in this seminar. And then finally, we explored Mary's self-image, portraying initially a pleasing, compliant self who was seeking validation and love from a powerful other. That was the sorority that was going to make her feel fulfilled, validated, whole, special, magnificent, etc., etc. And I've said that was last, but it really wasn't last, because I mentioned the punitive superego and that really critical inner voice that is also a part of depression that needs to be worked through. So I attempted to show you some of the therapeutic interventions that I found most helpful when working with Mary's depression, narcissistic vulnerabilities, and underlying emotional struggles. What were some of these therapeutic interventions? Let me just highlight them as we wrap things up here. 1, recognizing Mary's heightened emotional state, my initial priority was to guide her from a dysregulated condition to a more regulated one. I deliberately slowed down the pace of our sessions, of the content of her associations, and that fostered a space for a questioning conversation. 2, I placed a strong emphasis on helping Mary engage in, remember what I called verbal thinking. This intervention was crucial in guiding her to think through her experiences and emotions, especially when she was in a hyper-aroused, shame-ridden state. This is known as, and I quote, ego supportive. This is an ego supportive approach. 3, I employed acts of containment by inquiring about Mary's sense of specialness, attractiveness, and her imagined experiences in social settings. By appreciating her subjective experience, I aimed to transform her raw emotional feelings into cohesive verbal thoughts. That was the thinking that I keep mentioning. 4, a pivotal part of the work involved exploring Mary's feelings of invalidation, particularly in her interactions with her mother. This exploration helped Mary to recognize the recurring patterns of misattunement and the impact on her emotional state. And finally, this was the last one. I'm just highlighting them. Understanding that Mary's shifts in self-esteem, shame, and humiliation might also reflect an aggressive inner critical voice, I worked to facilitate the freer expression of her anger. This phase of the treatment was essential in allowing Mary to recognize and express her previously split off, there's the splitting, or redirected anger, which had contributed to her depressive state. Now, one thing that I didn't get into today, and maybe I'll pick this up in a future seminar, was Mary's relationship with her father. But that didn't really emerge until even much later in the treatment process when she started dating a guy who she felt was controlling. But that's a whole nother story. I won't get into the details of that today because we have to wrap it up. But I wanted to mention it just to show you and just to illustrate that it wasn't just issues around her mother, that issues with her father also began to play out, not to the same extent, by the way, and they were a lot easier to get through once she started to get involved in an intimate relationship. Anyway, I encourage you to reach out with any questions or comments regarding these really complicated processes. This topic is undeniably complex, and if there's anything I discussed that requires further clarification, please do not hesitate to send me an email. Additionally, I have supporting resources available for you, including recorded podcast episodes and videos on narcissism and depression. These resources can be accessed through my website. That's drmazzella.com. Until next time, engage your mind and continue exploring the depths of psychodynamic theory and techniques to enhance your practice and support your patients. Okay, bye for now. Disclaimer alert. This continuing education seminar is provided for general informational purposes only. The content presented is not intended to diagnose, treat, or cure any psychological conditions related to narcissism or any other mental health issues. The information provided in this seminar should not be considered a substitute for professional medical advice, diagnosis, or treatment. For specific advice or treatment related to personality disorders or any other psychological conditions, please consult with a qualified healthcare provider.